let's get started. Hello, and thank you for joining the Center for Learning Health System Sciences for our monthly Impacts seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website under the Education tab. I will post the link in the chat, along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for upcoming LHS events, the next seminar will be on June 4th by Dr. Jean Marie Gies of the Beth Israel Deaconess Medical Center. And with that, I will turn it over to Dr. Tim Beebe, to introduce our speaker.
Thanks, Stephanie. You can just call me Tim. So welcome everybody to today's seminar. It's great to have you here. It is my distinct pleasure and honor, actually, to introduce Dr. Debbie Pestka to the group today. She is a pharmacist, an implementation scientist, and a learning health systems researcher in our Center for Learning Health System Sciences here at the university. And she also has an appointment at the Center for Care Delivery and Outcomes Research at the Minneapolis VA, a longtime collaborator of ours. She is co-lead of the Rapid Eval unit within our center and affiliate investigator at the Minneapolis VA. She works with clinicians on a variety of practice areas to lead and consult on the design, implementation, and evaluation of their research. I'm proud to say that Dr. Pestka is one of our many successful and accomplished graduates of our LHS Mentor Training Program, joining us early on in our second cohort. I think she might talk a little bit about that in her presentation. So with that, I'll hand things over to Debbie to take things from here.
Thanks, Tim. Okay, yeah, so just kind of a outline of the presentation today. I'll start by just sort of giving a bit of introduction of how I got into the learning health system space. And then I'll talk about some of the learning health systems work that I do at the University of Minnesota. And then some of the work that I do at the VA. And then we will kind of compare and contrast the two, and then open it up for discussion and any questions that you might have. So just a bit of background about how I got into learning health systems work. First, I went to school to be a pharmacist. And then after that, I went on and got my PhD. Then I did a year of postdoc with a focus on implementation science. And after that, I participated in the University of Minnesota's Learning Health System K-12 program, where I spent 2 years applying LHS principles to evaluate a primary care transformation that was occurring at a local health system, mHealth Fairview, at the time. And then since then, I have worked as a learning health system LHS researcher, and I split my time between working at the university's Center for Learning Health System Sciences, or CLHSSS, and the Minneapolis VA. And those will serve as the two case examples I will share. So for anyone not affiliated with or familiar with the Center for Learning Health System Sciences, it's a collaboration between the University of Minnesota Medical School and the School of Public Health that began in 2021. And the center is made up of 6 units specializing in different methods and research areas. And I co-lead the Rapid Prospective Evaluation Program, or Rapid Eval as we call it, along with my colleague, Joe Koopmeiners. And to provide a bit of overview of how Rapid Eval is structured, we generally have 2 calls for proposals annually from our affiliated health system, mHealth Fairview. And applicants submit a form, and there is a review committee that goes through the forms and scores them. And then those with the highest scores are invited for a 30-minute interview. And of those that are interviewed, we generally pick the top 1 or 2. And some of the things that we are looking for is feasibility to complete the project and alignment with health system priorities. And so this is a list of projects that we have selected over the years. And you might notice that last summer we did not have an official call for proposals because leadership specifically asked that we work on a project around text messaging reminders for patients. And so then what we provide as the center to the projects we select is research and IT support. So on the research side, we provide consultation and project management in designing and evaluating the intervention, and plus dissemination of the findings. So helping to write up papers, put together posters for conference presentations, things like that. And then on the IT side, we have support from our colleagues at mHealth Fairview to build Epic tools if necessary and capture necessary data. And just as a reference, this provides a general overview of the process and timeline that we aim to achieve from an application being submitted to Rapid Eval to when it's submitted as a manuscript. So now I'll provide a case example of one of the projects that we recently we recently completed, focused on reducing unnecessary telemetry ordering. So as a bit of background, continuous cardiac monitoring, known as telemetry monitoring, allows for the prompt diagnosis and recognition of cardiac arrhythmias in hospitalized patients. But despite its benefits, overuse of telemetry can lead to alarm fatigue, bottlenecks, since there are a limited number of inpatient beds that are equipped for telemetry, poor patient experience, since patients are connected to a number of leads and wires while they're on telemetry, and just increased healthcare costs. And so to address this, the American Heart Association developed practice standards to guide appropriate telemetry use. However, these practice standards had not been fully embedded in mHealth Fairview. So a physician came to us with the idea of creating an Epic clinical decision support tool to facilitate ordering telemetry in alignment with the American Heart Association telemetry practice standards. And so before this project began, just as reference, there was over 2,000 inpatient telemetry monitoring orders monthly, which equated to over 140,000 patient hours on telemetry. So our IT partners were able to develop this clinical decision support tool so that whenever someone ordered telemetry, they had to provide an indication. And each indication was associated with a recommended telemetry duration. So you can see here, if it was acute decompensated heart failure, that has a recommendation of only needing telemetry for 48 hours. And then at the end of the duration, there would be a best practice alert that would display, and providers would be prompted to reorder telemetry if they felt it was still necessary. So the clinical decision support tool, along with this best practice alert, were integrated into the electronic health record, and we let it run for 14 months, which is a bit longer than what we typically aim for with Rapid Eval projects. But this was one of the first projects that we were taking on and still kind of working out our process at that point. So from an evaluation standpoint, we had two objectives. First, we wanted to look at physician variation in telemetry ordering before and after the introduction of this clinical decision support tool. And then second, once we identified who were high adopters of the American Heart Association practice standards and who were low adopters, we wanted to do qualitative interviews with individuals from both groups to understand their perspectives around telemetry ordering. And so I won't go into detail about the methods that we used for each objective just for the sake of time, but just to give a high-level overview, we stratified physicians that were ordering telemetry into those that were using it in excess of what the American Heart Association recommends and those that were not. And we found that on average, both excessive and non-excessive users decreased overall telemetry use after the EHR tools were in place, and that these reductions were sustained. And then telemetry monitoring use that was in excess of the American Heart Association standards continued to decrease after implementation, only among excess users, but not among non-excessive users. And even with these tools in place, about 10% of all telemetry continued to be outside of the AHA practice standards. And again, I don't want to go into depth about the methods that were used for the qualitative data collection and analysis, but both the quantitative and qualitative analyses were done by the Rapid Eval program as part of the services we provide. So after we had stratified providers into those that were using telemetry in excess of what was recommended and those that were not, we conducted qualitative interviews with individuals from both groups. And there were a number of themes that came out. So for example, several interviewees mentioned some of the existing care team beliefs that may contribute to telemetry overuse. For instance, some felt that telemetry monitoring can provide a safety net if you're unsure what is happening clinically, and that it provides an additional monitoring point if something were to go wrong. So in an interview, one physician said, "I do like it as a higher level of care, meaning I want this patient looked at a little more often. I want an alarm to go off if something's going wrong, kind of the same way I use continuous pulse ox, because I just want a closer eye on that patient. And if we have them hooked up to something that'll ding an alert when something's going wrong, that's really why I choose to put it on there." On the other hand, some interviewees really liked the intervention because it felt like it made them think more critically about ordering telemetry and provided a litmus test of whether telemetry monitoring was really necessary. As one physician noted, let's say I want telemetry for a reason and I look at the CDS and it's not one of the standard reasons and I have to use the other tab. It makes me evaluate whether or not I really, really want to use it. There were also a number of concerns about the telemetry practice standards that were brought up. Participants mentioned several gray areas where they felt the practice standards did not fit well. For example, it was mentioned that patients may have multiple indications during their stay, which complicates selecting a single indication for telemetry monitoring. Also within the system, there are intermediate care units that have cardiac monitoring capabilities. And it was brought up that there was internal professional debate on how the telemetry initiative should be used for these patients. And one interviewee expressed desire for more direction on ordering telemetry for this population. They said, if you look at an IMC patient in intermediate care, I have a lot of providers I encounter who believe all those patients should be on tele, and nurses too. Then there are those who don't. That's a huge controversial point. I think we as a system need to either educate not to use it there or offer a button on that cardiac monitoring order for IMC, just because I think we get a lot of wildly inappropriate, goofy, other indications typed in because of that particular class of patient. So sort of the final takeaways from that project are that by using a mixed methods approach, we showed that the intervention reduced telemetry use across both excessive and non-excessive users of telemetry and in a sustained manner. But unnecessary telemetry use did still persist to some extent. The qualitative component uncovered that physicians from both groups saw the intervention as beneficial, but struggled to apply the standards in gray areas, and pre-existing beliefs about the benefits of telemetry may lead to variation in acceptance. And, I don't specialize in cardiac research, so I was not familiar with the existing literature in the space before I started working on this particular project. But after getting into this work and reading some of the background literature, One of the takeaways for me was that this was not the first study to look at an intervention to reduce unnecessary telemetry monitoring. Many health systems have been trying to do this for years. And what I think made this project unique and helped to add to the literature was that it was mixed methods, was really the mixed methods component, and that we really delved into not just effectiveness, but applying an implementation science lens to look at provider adoption of an intervention and what factors contribute to the uptake of implementation of an intervention, such as the one we had in place. Okay, so that was an overview of some of the LHS work I do at the university. So now we will switch gears a little bit and I will go over one of the projects I've been involved in at the VA. But I'll also just pause if there are any questions at this point or any questions on that specific telemetry project.
Debbie, there are not any questions at the moment.
Sounds good. We'll keep going. So just a broad overview of the VA. The Veterans Health Administration is the largest integrated healthcare system in the US. They have over 1,300 healthcare facilities and serve 9 million veterans each year. And the VA is divided into 18 different regional systems of care across the US called Veterans Integrated Service Networks, or VISNs. And one of the things that they do at the VISN level is called strategic initiatives. So once a year, they do a call for proposals to identify quality improvement projects that will be implemented at the VISN level, aimed at addressing VISN priorities and current gaps in care. So the project needs to include at least 2 VISN sites, but most are implemented across the entire VISN. And I'm more distant from the selection process for these, but I believe the objective is to usually pick 2 to 3 projects a year, depending on funding. And what is different from Rapid Eval is that the VA provides funding for staffing and resources needed to execute the project. So if you need to hire 3 nurses, let's say, to deliver a proposed model of care, they will cover the salary costs of those nurses. And one strategic initiative project that I've been involved with for a couple of years now is looking at a pharmacist-driven outreach initiative to increase prescribing of a medication that's shown benefit to patients with chronic kidney disease. So just a bit of background about this. Chronic kidney disease, or CKD, is a common condition that affects about 15% of US adults. And patients with CKD, through various mechanisms, are at heightened risk for cardiovascular disease and cardiovascular events. However, recent studies have demonstrated that a medication class that's usually used for diabetes, called SGLT2 inhibitors, have shown benefit on reducing cardiovascular death, major adverse cardiovascular outcomes in patients with CKD, as well as decreasing the development or worsening of nephropathy. And as a result, the American Diabetes Association now recommends that all patients with type 2 diabetes and decreased kidney function take this medication. And while the effectiveness of SGLT2 inhibitors has been well documented, strategies to improve prescribing of this medication to patients has not been evaluated previously. And pharmacists play an integral role in patient care teams. They have expertise in medication management, and in many states, they can prescribe medications. So the purpose of this project is to evaluate the impact of a targeted pharmacist outreach initiative to start patients on SGLT2 inhibitors compared to usual care. And for this project, as sort of a pseudo randomization, patients meeting the eligibility criteria with an odd social security number receive the intervention, while those with an even social security number serve as the control. And the project was started in February 2022, and the plan is to spread the initiative to all VA sites in the VISN to gather data, and then we'll go back and offer the intervention to those with an even social security number after all of the odds are completed. And so there are 2 pharmacists on the team, along with a medical assistant, and they work to go through the patients that meet the eligibility criteria and have an odd social security number, and reach out to schedule a virtual pharmacy visit. And during the visit, the pharmacist reviews the veteran's existing medications and medical history and discusses the possibility of starting the medication with the veteran. So the project is anticipated to run through 2025, and we are still in the process of collecting data and analyzing the data to examine interim effects of the intervention on SGLT2 inhibitor uptake, as well as clinical outcomes. But this graph just kind of shows the overall difference that can already be seen at the VISN level compared to what's happening nationally. And it's important to note that the green line is the entire VISN. So it's both the intervention and the control in there. So if we just parsed out those in the intervention arm, you'd likely see a much greater impact. And then I just include this table because it was really a pragmatic decision to create the pseudo-randomized approach by using the last digit of the social security number to put people into different groups. But this just shows that it created a balanced approach, and it was very easy to execute from a system level. Okay. So we have looked at 2 different LHS projects from 2 different systems. So now we can go ahead and compare the 2. So starting with what is offered, kind of as I said at the beginning, so in the center in Rapid Eval, what we provide is the research and project management and IT support. So that is offered free of charge to the clinicians that we are working with that bring their projects forward. And so if they have any projects that require special equipment or things like that, that is something that we do not cover. They would have to find system funds in order to do that. And then on the other hand, at the VA, what is offered, I mean, it's almost like submitting a research proposal where you have to submit a budget and you have to say, what % of salary support you need, equipment that you would need. So another strategic initiative I'm working on is looking at mailed fit kits for colon cancer screening. And so they had to include the fit kits, as a budget line and the cost associated with that. And then they were awarded the strategic initiative, so they did get funding to buy that. So that's just a bit of a difference between, what is offered between the 2 groups. And then as far as timeline, with Rapid Eval, we shoot for a timeline of having the intervention run for 6 months and then evaluate that. It's not strictly adhered to, but that's what we aim for. And then with the strategic initiatives, they let it run for 2 years, at which point you have to present results to upper leadership. And then if they see promise and they see value in the initiative, then they will continue to fund it long term. But if there really hasn't been any movement in the needle in terms of progress, then it'll end at that 2 years. And then as far as focus goes, kind of my perspective is that, at the VA, it's kind of shifting. They're putting more emphasis on research, but it seems like in the past, the focus has really been more on fixing a clinical problem or a gap in care. And, you can do a little evaluation on the side if you want to. And so now there's more of an emphasis on, wanting to be a learning health system and structuring these projects so that there is more of a research component. But that's just sort of been my observation so far, is that, historically, it's sort of been more focused on fixing a clinical problem, where I feel like rapid eval, we very much select a project based on the ability to create and have, quality data at the end of it. So we've kind of hit the main points that I was hoping to cover. So that takes us into the discussion and question period. So I will open it up now to see if there's any questions or comments.
Yes, we do have a question. Rubina wanted to know if you found any variability in telemonitoring ordering by attending physicians' years of experience.
That's more of a Mike Usher question. I don't know if we looked at that. We do have a companion paper that kind of drills down into more of the sort of clinical outcomes and more of what you're referring to. But it's been a while since I've read that, so I am not sure. But that is a very good question and definitely kind of a key aspect of adoption.
All right. And, Rubina would like to know what that paper is, the reference.
Oh, sure. Yeah, I can send that out.
Okay.
I think it was just published last week.
Okay. And also, could you share a couple of unique challenges facilitators at each location? What was the IRB implications at the VA?
Yeah. So I'll speak to the first part, and then if you can re-ask me the first part of that question. So IRB at the VA, I think, so the strategic initiatives are really set up to be quality improvement projects. And so that's how they're framed when they're submitted to the IRB. So my experience with the strategic initiatives that I've been involved in is they have gotten passed as strategic initiative projects. So I know at the VA, like they're very particular about what's QI and what's research, because QI data can be stored somewhere, but research data has to be stored someplace else. But the way that these strategic initiatives are set up, they are sort of geared to be quality improvement projects, and so that's how they go through the IRB. And so can you say again the first part? So facilitators and barriers to doing learning
Yes.
health
So what were the
systems
unique challenges at each location?
Well, I think at the VA has a reputation for hiring taking an immense amount of time. And so there can just be a lot of project delays, or there's hiring freezes and things like that. So I was working with a physician on one project that is, basically kind of on the back burner until she can hire somebody. And it's been on the back burner for about a year now. Just because they've had a hiring freeze of that position. So that's been a major challenge. And then I think a facilitator of the VA is, I think it's very much sort of already has a culture of being a learning health system, and just, participating in research and having ways of accessing the data and having sort of a research core already in place. So that's been a real benefit. And then at the university, let's see. So a barrier of the university, I think it's much more sort of developing as a learning health system. So there's just a lot of learning curves and bumps in the road that come with that. And just, who do we need to talk to get something passed through? Who needs to have a seat at the table in order to get this up and running? So it's just kind of learning some of those things earlier on. That's been sort of an initial barrier. And then a facilitator. I mean, I just like that we're able to take on so many projects, and just the variety of projects that we've been taking on has just been really professionally rewarding and satisfying to be able to help in so many different clinical facets.
Great, thank you. And just to let everyone know, we have plenty of time for discussion. You can post your question in the chat, or in the Q&A, or raise your hand and we can unmute you. We have plenty of questions. Genevieve asked, with your background in implementation science, what advice would you have for researchers who want to learn more about how to apply these methods to their projects?
Yeah, so I think that there are defined implementation outcomes. I think that there's always kind of the tendency to lean more towards the clinical effectiveness and, is this going to lower A1C? Is this going to decrease this adverse outcome that we're trying to look at? Whatever it happens to be. But there's also implementation outcomes that are hugely important to the success and sustainability of an intervention that I think need to be taken into consideration as well. And, some of those are, what do people that are on the ground using this intervention, do they see it as feasible to continue to use long-term? Is it acceptable in their eyes, appropriate? Looking at adoption, sometimes whenever something new is started, there's always, early adopters, people that kind of buy into it. And then there are laggards and people that just kind of, they need to see data before they buy into it. And so I think looking at adoption and how to increase adoption of best practices is another area, as well as sustainability, because, a lot of times, especially with grant-funded projects, once the funding goes away, it's kind of a mystery as to whether or not the project is able to sustain without that grant funded support. So also looking at sustainability of a project is important to consider.
All right, Lindsay Welton wanted to know, can you share if there are any specific pitfalls you notice new scholars frequently encounter compared to others who are more familiar with this process?
No, no, I mean, I'm just trying to think. I think that, in a perfect world, the learning health system approach is meant to be more flexible. And some of the people that I've worked with are really used to a more kind of rigid, and this is our protocol and we can't deviate from it. But I feel like there has to be some flexibility with LHS work because that's just the nature of practice. I mean, we all had to change what we were doing dramatically because of COVID. Things just happen. That's just one example. And so I think that sort of flexibility needs to be in place and adaptability when doing learning health systems research. And I think that that's just something that I've sort of observed working with new clinician researchers, is not really knowing, like, can we do this? Is this okay? And it's just sort of learning by doing.
All right. Dylan wanted to know, was there any influence of vendor on learning health system? Like the VA is Oracle Cerner, and I believe the U has Epic Systems. Was there a difference in the LHS perspective between vendors?
Oh, I don't know that I can answer that. Yeah, I know the VA is in the transition of switching their EHRs, and so I think that will have an impact on data collection and just LHS work, but I really can't speak more to the whole vendor question. That's kind of outside my wheelhouse.
All right. And Rebecca wanted to know, from your experience, what do you think are the most meaningful metrics that reflect the degree to which an organization is operating as a learning health system? What does optimal state look like, and how closely does the VA resemble this optimal state?
So I do have a few more slides. I wasn't sure if there would be time, but maybe I'll kind of go through those just to sort of answer that question in a long-winded way.
We have time.
Okay. All right. So I'm a pharmacist, and most people, when they think of a pharmacist, they think of the pharmacist, behind the counter at Walgreens, CVS, dispensing medications. But starting in the 90s, pharmacy really tried to kind of move away from that. They realized that people were being hospitalized because of medication-related problems. People were taking medications they didn't need to be taking. They needed medications that they weren't on. Medications they were taking weren't effective. They were having adverse side effects. They weren't adherent, all these things. Oops. And so there's really been a push to, kind of take pharmacists out of that dispensing role and put them, they're completely outside of the pharmacy. They're embedded in care teams where they meet with patients and go through all of their medications to make sure that they are working as they should, that they're taking the right medications, they're not having any side effects, and that they're adherent. And then if they identify any problems during that process, any medication-related problems, they work with the patient and the care team to resolve it. And so the most frequently used term for this is medication therapy management, is what this service is called. But for a variety of reasons, it's really just sort of failed to take off. And a lot of that is because there's just all this confusion around terminology of what the service is. It's also been called pharmaceutical care, comprehensive medication management, medication therapy management. And then there's been a lot of confusion within the profession of what constitutes medication therapy management, because you have some pharmacists that will just manage a patient's warfarin, which is a blood thinner, and say, okay, I just did medication therapy management. And then you have some that will manage a patient's diabetes medications and say, okay, I just did medication therapy management. And then you have pharmacists that look at all the medications a patient's taking and say, I just did medication therapy management. So a lot of pharmacy organizations have attempted to sort of define what is the process, like what are the steps that need to occur in order to call it medication therapy management. So ACCP is American College of Clinical Pharmacy. They came out with a white paper on, kind of creating the essential steps of this process. The American Pharmacists Association, they came up with a model sort of outlining the process of medication therapy management. Patient-Centered Primary Care Collaborative, they came up with 10 steps that need to happen in order for it to be medication therapy management. As well as the Joint Commission of Pharmacy Practitioners, they came together, put together a model. And then there was, a research group, CMM and Primary Care, and they put together a document outlining the essential steps. And so, kind of the point that I'm trying to make is that pharmacy has really kind of struggled to take off. Payers are really confused about what medication therapy management is. Is it just sort of managing one drug class, or is it managing all of a patient's medication? And so because there's that confusion, they don't really know what they're paying for. Patients don't really know what it is. I'm guessing many of you have probably never heard of it. And so, it's been, it's been 3 decades that this has been in process, and it's still kind of yet to gain a lot of momentum. And what concerns me is that I see a lot of similarities between this and what's happening with learning health systems, where I've seen a lot of different models come out, trying to define what makes a learning health system and what needs to be in place for a learning health system. And all these different definitions of what constitutes a learning health system. And so, me just coming from the pharmacy world, my concern is if we do not have a unified definition of what a learning health system is and what learning health systems research is, like what is a learning health systems research project versus one that is not a learning health systems research project, we're going to fall into that same pit hole of, funders aren't going to know what LHS research is, so they're not going to want to fund it. Readers, when we publish and say that we're doing learning health systems work, they're not going to know what it is. And so it's just going to be detrimental to the field. So I don't mean to end on kind of a doom and gloom note, but that's just another observation that I have kind of working across systems and people asking me all the time, what is learning health systems? That's just sort of what I've observed. It's just sort of this need to come together and really kind of create a unified definition of what it is that we do and what constitutes a learning health system, as well as learning health systems research. So to answer that question, so yeah, I don't really have an answer for that question, except to say that we need more professional discussion on that.
This question is adjacent to your answer. So Melissa wanted to know, given your experiences, can you talk a little about the role and importance of both formalized training and LHS principles, as well as mentorship for those looking to work within learning health systems?
Yeah, I'm not too familiar with formalized training in LHS. Like, I'm not familiar with any coursework or certificate programs or anything like that. I know we do have the K-12 program, but again, that's a mentored career development award. So you get that kind of learning and experience through actually doing the work and through mentorship. So that's really all I can speak to. But I do think that having more coursework and making it more broadly available through training opportunities would be really beneficial.
All right. Well, it looks like you've answered all the questions. And I will wait a minute just to see if any more come in. But thank you, Dr. Pestka, for taking the time to present at the CLHSS Impact Seminar. And thank you all for attending. Please, again, join us on June 4th for our next seminar, which will be at noon Central Standard Time. And this concludes our presentation. So thank you all. See you next time.
Thanks, Debbie.
Thank you.